Welcome to this lecture on immunosuppressive agents. Here we will be talking about Cyclosporine, Tacrolimus and Sirolimus, and a little bit in detail of how it causes the side effects as well as how it causes its effects, that is its mechanism of action. Let's see how the cyclosporine acts. Cyclosporine will bind to cyclophilin. So what is a cyclophilin? A cyclophilin is a cytoplasmic protein. So what is the role of cyclosporin cyclophilin complex? They will bind the calcineurin. Now what is calcineurin? The calcineurin is a calcium calmodulin dependent serine threonine phosphatase. What does it mean? Calcium calmodulin dependent. Once the T cells are activated by the primary signaling and the secondary signaling, calcium will enter into the T cells. Now this calcium will combine with the calmodulin and it will activate the serine threonine phosphatase. This entire unit, calcium calmodulin dependent serine threonine phosphatase, is the calcineurin. Its normal function is dephosphorylation. It will dephosphorylate the NF-80, that is the nuclear factor of activated T cells. Once it dephosphorylates the NF-80, the NF-80 will move into the nucleus and it will stimulate the interleukin-2 gene transcription. This will drive the T cell activation and the proliferation. Coming on to the mechanism of action of cyclosporine. Cyclosporine enters the T cells, it binds to the cyclophilin and it forms the cyclosporine cyclophilin complex. This complex will inhibit the calcineurin. As a result, NF-80 stays phosphorylated. If it is phosphorylated, it cannot enter the nucleus. So there will be decreased interleukin-2 transcription and decreased T cell activation. The net effect is suppression of cell-mediated immunity. Cyclosporine will suppress the T cell-mediated immune responses by inhibiting the calcineurin. That's why it is widely used in organ transplantation as well as in autoimmune conditions where we don't want the T cell to get activated. We know in brief with this mechanism of action that it decreases the action of calcium. So calcium forms a complex with calmodulin and that is how the steps progress. But with respect to its toxicity, it causes neurotoxic as well as nephrotoxic. So how does it cause nephrotoxicity? How does it cause neurotoxicity? It will cause nephrotoxicity because in renal vessels it will increase the endothelin 1. Therefore, and it will also decrease the nitric oxide and the prostaglandins. Therefore, it is a potent vasoconstrictor and that causes nephrotoxicity. Even in the systemic blood vessels, it is a potent vasoconstrictor. Therefore, it will result in a hypertension. It can also result in hypertrichosis. And the cyclosporine can also cause vasoconstriction of the cerebral vessels because cyclosporine can enter the CNS. Vasoconstriction of the cerebral vessels will result in decreased cerebral blood flow, which can lead to tremor, headache, and seizures. So, cyclosporine can cause nephrotoxicity, neurotoxicity, as well as hypertension. Cyclosporine, will it cause diabetes mellitus or not? Cyclosporine does not cause diabetes. But whereas Tacrolimus, whose mechanism of action is almost similar to cyclosporine, does cause diabetes. Let's see how. Tacrolimus. Tacrolimus, what is the clinical profile? Tacrolimus is similar to cyclosporine in inhibiting the calcineurin, but it inhibits via a different binding partner. What is the binding partner? The binding partner is FK506. The tacrolimus, it is the FK506 that will bind to FKBP. So tacrolimus is also, you can remember it as FK506. It will bind to FKBP. The FK506 FKBP complex will inhibit the calcineurin. So the mechanism is similar to cyclosporine, but it binds via a different binding partner. And the following pathway is the same. That is, it will decrease the interleukin-2 transcription, it will decrease the T cell activation. It is, but and similar to cyclosporine, this is also nephrotoxic, this is also neurotoxic. But tacrolimus is diabetogenic, but cyclosporine is not diabetogenic. This is because the effect of cyclosporine on the pancreatic beta cells is very minimal. But the effect of tacrolimus on pancreatic beta cells is very high. It will decrease the pancreatic beta cell response, and it will decrease the pancreatic beta cells ability to produce insulin. Therefore, this is more prone to cause diabetes mellitus. Post-transplant diabetes mellitus is caused by tacrolimus. So just in short, both cyclosporine and tacrolimus will inhibit the calcineurin, but cyclosporine will bind to cyclophilin and tacrolimus will bind to FKBP. The cyclosporine will cause nephro and neurotoxicity. Tacrolimus is also nephro and neurotoxic. But cyclosporine will not cause diabetic because its concentration in the pancreatic beta cells is reduced, while tacrolimus causes diabetes mellitus. Let's see about the Sirolimus. Even though Sirolimus and tacrolimus bear the same rhyming name, Sirolimus mechanism of action is entirely different from tacrolimus. Sirolimus will bind to FKBP, just similar to tacrolimus, but the Sirolimus FKBP complex, unlike tacrolimus, does not inhibit calcineurin. The Sirolimus FKBP complex will inhibit mTOR. What is the role of mTOR? mTOR is a kinase that will regulate cell cycle progression. So by inhibiting the mTOR, we block the T cell proliferation which occurs in response to interleukin-2. So in crux, the cyclosporine and tacrolimus will block the interleukin-2 production, but Sirolimus will not block the interleukin-2 production. After interleukin-2 is produced, the cell cycle happens and T cell proliferation happens. So that cell cycle is inhibited by Sirolimus by inhibiting the mTOR. Regarding the toxicity profile, mTOR is present in abundant amount in beta cells. So beta cell growth and proliferation is also inhibited by Sirolimus. Therefore, Sirolimus causes diabetes, but it does not cause nephrotoxicity and neurotoxicity. It also causes dyslipidemia, and elevated cholesterol and triglyceride levels are also caused by Sirolimus. Sirolimus will have an mTOR inhibition effect, which will disrupt the normal adipocyte differentiation and maturation process, resulting in an impaired cellular lipid uptake and processing by adipose tissue. So in short, Sirolimus can cause diabetes mellitus as well as dyslipidemia. Therefore, when Sirolimus is administered, lipid panel should be monitored regularly. With this, we have come to the end of this immunosuppressant topic, where I have discussed the 3 important drugs and the differences between them. I hope this is useful to you. All the best to whatever exams you are appearing. Have a good day.